I would like to invite Dr. Fairooz. She is from Bangalore. She is going to speak about socket reconstruction. Yes, yes. Fairooz is well known to all of us. She's even though she's not staying in Kerala, she is a Keralite. I would rather say NRK oculoplastic surgeon. She's a medical director of Horus Specialty Care at Bangalore. Over to Dr. Fairooz, please.
Good morning to everyone. Of course, I'm more a Malayali than anything, based in Bangalore. And it's a pleasure to be back in Thrissur because this is where I started my journey, my endless journey of being in medicine. And it's an honor and pleasure to be here with my own people. Thank you, Marian, for including me in this session. Can I have my slides on? Yeah. So I'll be talking regarding contracted socket, and a contracted socket is, something that most of the time that as ophthalmologists we ignore. We kind of tell the patient, okay, you can wait. But for a patient, it is so very important. And in my practice, I give it so much of a value because you are valuing that individual, because that person with a contracted socket and a facial deformity undergoes a lot of social stigma. Be it personal, be it professional, even, interacting in a social a forum with, lifetime well-being is affected once when you have a contracted socket. So I find it so interesting to deal with these contracted socket and, get the things fixed for the patient. And that's exactly what I'm going to do today. Just discuss few cases. Are we on? Yeah. Yeah, it's fine. Okay. Good. Yeah, perfect. Yeah. Okay, so this is what we are going to do today, okay? Yeah. And these are my affiliations and my financial disclosure. So as I said, it has a cosmetic blemish. It definitely has a psychological impact, social anxiety in these patients, and very low self-esteem. And when you deal with these patients, this is what you're improving. You're improving a changing a life of these patients. Now, this is a 36-year-old lady, history of vitrillage. All right. So you can see, fortunately, the left eye is perfect. She sees with that left eye. More affected is the right side. And she has an eyeball inside. Okay, she has a thusical eyeball with almost a grade 4 contraction over here. So my question would be, would you like to intervene? Anju? Yeah, yes, observe. You would try, right? I would definitely try, okay, yeah. So what I did in this case was, I released the ankyloblepharon, there was a symblepharon release, and then I did a large mucous membrane graft. This is all that I did, nothing great, all right? And she has an eyeball inside, which is blind. And mainly what is happening here is she has a volume, but it's mainly a surface loss, all right? So mucous membrane grafting and fornix formation sutures in this, yeah, so this is after the placement of the prosthesis. So a prosthesis could actually go inside with an expansion of the surface. Now this is grade 5 enucleated and radiated socket as a child for retinoblastoma. Well, the good advantage in this patient is he has kind of a very shallow and deep-seated socket. So he doesn't have volume, but it's a radiated socket. Giving a volume in this case, the only option that I have is a dermis fat graft, but well, dermis fat graft is very, very risky when it's vascularly compromised socket, all right? So what I did was, I didn't take too much of a risk. The only thing that I did was to place again a large mucous membrane graft and give him a prosthesis. He's extremely happy. All right, and the shrinkage of mucous membrane graft, if you place a large one, is quite unlikely. But if you keep a very, very small one, well, there is a chance of shrinkage as well. Now, So this is how the mucous membrane graft is taken. You can take from the buccal mucosa or the labial mucosa as large as possible, and as you can see here, you have to keep it very, very folded in the socket. So I do have a video here. How do I play this? Okay. Okay. I'll take you through very quickly. I'm sure most of you do a mucous membrane graft. So this is how we, this is basically traction sutures. This is a socket. I inject it and then, separate the conjunctiva from the subconjunctival fibrosis. So this is the center. I have actually marked the fornices, the lower and the upper fornices, from the lateral to the medial canthus. And before putting the graft, what I do is I actually fix the fornix. The fornix is fixed so that I exactly know what is the size of the graft that is required. This is the graft from the lip, a large graft, okay. An amniotic membrane graft is placed so that healing is good, and this is how you actually harvest the graft, and this is how big the graft is actually, not just fitting, but it has to be really, really folded. So once when you keep the conformer, it really expands and it gives a nice surface. And finally, after the placement of the graft and the conformer in position in the center, then you actually tie the fornix formation sutures, and this is how it goes. All right, now this is a contracted socket patient with granuloma, a long history, 50-year-old gentleman, frequent bleeding, road traffic accident, enucleation without implant, secondary implant extrusion, repeat implant placement twice elsewhere, and then a mucous membrane in the lower fornix. Okay, so when he presented to me, he had this bleeding happening, and this is how his fornix is. Okay, now what do? I really don't want to touch too much into the socket because it has been operated 3 times, 4 times. Why do I even want to go inside and create more scarring, right? The only thing that I did was to form the fornix for him and a lateral canthoplasty. That's it. All right, and of course, I've been treating the granuloma with injection of triamcinolone acetonide. That's all that I did. Very minimal, but the patient is happy. Now, contracted socket with customized oculoprosthesis. He has a contracted socket, no implant inside, but the patient is okay. The prosthesis is beautiful. The color matching is so beautiful, all right? But then it doesn't look that great, all right? He did have a nice surface. So what I did was to give him a secondary implant. And yes, so the placement of secondary implant also depends upon how good the ocular surface is. If the ocular surface is good, you can always go for a secondary implant. But then otherwise you have to think of other things which we will discuss here. So what is contracted socket? This is just for the PGs where reasonably sized prosthesis cannot be placed or retained. So we have different classification. I'm not going into the detail. It's just to give you a highlight here. Grade 0, grade 1 where 1 fornix is involved, 2 fornix involved, grade 2, grade 3 when all the fornixes, upper and lower fornix is involved. Now this is where the palpebral fissure has completely closed. Grade 5 is a refractory socket. Okay. Now another classification is congenital and acquired. You can have bony contraction, soft tissue contraction, and both contraction. Now going on to management, if there is congenital microphthalmia or anophthalmia, you can give serial conformers as in this case, and finally a customized oculoprosthesis. But now in my practice, I actually use serial customized oculoprosthesis right from the beginning. And this is how early we start. At 2 months, this child started receiving customized oculoprosthesis. At 3 years, I actually enucleated, gave him an implant, and this is how he looks like. This child, how early? At 27 days, this baby came to me. Immediately, I started. This is just before her first birthday at 11 months, and this is like last month I saw her at 4 years. Now, this is a patient who have presented when he was an adult. He was 24 years when he came to me. A little bit difficult, but still I don't give up. I usually don't give up in my life, all right? So what I did was dermis fat graft in him, okay? Dermis fat graft, good prosthesis, and well, he was so happy he got married, and he has a beautiful wife. All right, yeah, so basically the principle is look for surface loss, look for volume loss, and both surface and volume loss. I'm going to share my secret to you. Okay, so this is what works for me. This is exactly what I do. I look for a shallow fornix, how the fornix is. Then I evaluate the surface loss and the volume loss. I'm not going to explain the whole thing. You can take a picture and we can discuss later. And depending upon that, I plan my management. If the surface loss is really bad, but there is volume, it's just the MMG or AMG that you have to think of. Volume and surface, then dermis fat graft. And well, we do have other options like exenteration prosthesis. Now, phonics formation suture, never compromise on this. Just don't think that you'll put a good AMG or DFG or MMG and then put a confirm and it's going to work. It's not going to work, all right? You have to fix the phonics. You have to go fix the phonics, taking it through the periosteum so that it's permanently staying there. And that's so very important. Please don't compromise on that. All right, and well, this is how it looks like. And this is a patient. He was an army officer from Yemen, and he had an injury with bullet in his eye. Okay, eyeball is shrunken, lateral canthus is gone. So what I did was dermis fat graft, lateral canthoplasty, and this is how he went back. All right, this patient had evisceration and he had integrated implant. We used to have this where motility was improved earlier with a pegged integrated implant. It has complications of granuloma. We no more do it, and he had severe complications. The implant was taken out, it extruded, and this was how sad the patient was. He's like, I have to suicide, I cannot live, all right? Well, so what I did was treated his socket, of course, severe granuloma for almost 2 months, and then that is with the conformer up there, and this is the prosthesis. Well, not super great, but well, he was happy about it, and I was also satisfied. So this is what we do in dermis fat graft. I usually take it from the buttocks, and this was my thesis when I was a postgraduate student. So my colleagues and my teachers used to call me the buttocks doctor, because all the patients with stitch in their buttocks, it's my patient, all right? 32 cases, all right? So I have been loving this surgery right from then, and this is how exactly dermis fat graft looks like. So going back, you have a surface which is almost 20 millimeters, and then you have a volume. What else do you want? You're getting the volume and you're getting the surface, all right? Yeah, so let me see whether it quickly Okay, so this is the gluteal region, my favorite region. I work on my glutes also. So this is where I take it from. Okay, yeah, I'm just going to go through. So this is how it goes. So dermis fat graft, initially it looks like white, and then it conjunctivalizes. So a conjunctiva is growing over it, a new conjunctiva, a new surface is growing over it, and this is how it looks like. Okay. So this is again a road traffic accident, globe rupture, faciomaxillary fracture, enucleation plus implant elsewhere, and he has a dacryocystitis, secondary saldo, dacryocystitis. So what I did was dacryocystectomy and medial canthoplasty in step 1, and then what I did was MMG and FFS in the stage 2. And this is how overall he looks like. So there is a combination of everything that happens in these patients. Grade 5, enucleated, radiated with multiple socket surgeries. She was referred to me, to my ocularis for exenteration prosthesis. All right, so well, as I told you, I don't give up much in life. So I thought, well, giving her an exenteration process, she's so young, she's going to have a long life to live, right? So what I did was I tried. I again gave a large mucous membrane graft, and this is how she looks like. Not an exenteration prosthesis, but well, there is definitely, this patient was surgery phobic because the child has undergone multiple surgeries, and the father is like, no, we don't want any more surgeries, but give us some other solution. And then she received an exenteration prosthesis. So well, I'm done. This is how the summary is, what works in grade 1, grade 2, grade 3, grade 4, and grade 5. In short, so it's so very important to have a very meticulous assessment to decide what was the cause and what would be the effect if you intervene and if you don't intervene. And taking a wise decision in socket is very, very important. Thank you so very much, and this is where I all started. I'm so happy to be here, to be in Thrissur. Thank you for having me here. Thanks a lot.
Thank you so much for that lucid presentation on socket.